Good. Okay. I'm going to share my screen. And while I'm doing that, I just want to say good morning to everybody. I hope the morning sessions have been entertaining and informative and fun for everybody. Um, so can everybody see that? Okay, good. So what I thought we would do is for a little while here, go over just some general information about heart transplantation and kind of where we are today with a few things. And some of this will be um, well known to everybody. Some of this, it may not be well known, but I'll try to
Excuse me,
use,
Doctor. Kimberly has a question.
excuse me?
Kimberly has a question. If you unmute yourself, Kimberly, he'll be able to hear you.
Okay, I'm on the lung transplant list. Is this the right group?
Nope.
No,
you need
no,
to be in
ma'am.
the lung group. Hang on
I
just a
don't
second.
know how to do that.
Okay, we will take care of it for you. Just hang in
Thank
there.
you. Okay.
Okay, well, we'll get that straightened out. So, um, I've got it divided up into two parts, and the first part is kind of pre-transplant issues. And really, with this, I'm going way back. I'm going to show a little bit of some history of where we are with heart failure and transplantation. And so here are two sort of ancient drawings of people with heart failure. You can see here that these people have ascites or abdominal swelling, and they're weeping, and their legs are swollen. And this was always referred to as dropsy. Everybody's kind of heard that phrase, oh, my grandmother had dropsy, but that term goes to the swelling that goes along with heart failure. Now, it used to be, we have come a long ways, so it used to be that one of the main treatments for dropsy or hydropsy was bloodletting. And so on the left here, you can see the leeches in the bottle. You can see somebody using some instruments to let blood. This is an old figure from a textbook showing some bloodletting instruments, but it was said that it is the least equivocal of remedies. It's good. This is so immediate and striking. In short, bloodletting is a remedy which, when judiciously employed, is hardly possible to estimate too highly. It makes me think I'm so glad that we now have better medicines and better treatments than bloodletting. Now, transplantation also, everybody has thought about this really since the beginning of time. This is a painting from the 15th century. This is called The Miracle of the Black Leg, where two surgeon brothers who were, the story was that in the 3rd century in Asia Minor, these two surgeons tried to transplant a leg from one person onto another. And you can see that it is striking in this case because the recipient is white, the leg is from an African Black patient. And you can see an angel down there. I think that's an angel. And but people have been thinking about transplantation for a long time. And as early as the 6th century BC, the Indian surgeon Sushruta described trying to reconstruct a facial wound by transplanting skin. And so I imagine that none of these went extraordinarily well until we get up into the last generation or two from us. But if we move forward a bit, we can see that in 1905 was the first successful human corneal transplant. That came early because the cornea doesn't have vasculature, and so it's a little bit different than a lot of other of our tissues, but it was done in 1905. In 1954, we had the first successful kidney transplant that was done between twins. And in 1957, really the first immunosuppressive agent came onto the market, which was azathioprine. We also call that Emuran. And so So we started making some headway here in the 50s. In the 1962 was the first successful deceased donor kidney transplant. 1963 was the first lung transplant. And then, so this is the heart session, so we're focusing on heart. And so 1967 was when Christian Bernard did the first heart transplant. And this made the cover of Time magazine. Christian Bernard sort of scooped everybody. He was South African and came to the States to learn the procedure, and then raced back to South Africa and was able to scoop everybody by doing really the first successful, and you can see the first successful heart transplant. It became widely famous, and there was a lot of press around this. And so in 1981, Dr. Shumway, who was involved with teaching Christian Bernard, did the first heart-lung. And then everything changed. And so it took until 1983 for us to develop and get cyclosporin. In a heart meeting recently, I met the person who was at Minnesota, who really gave the first people cyclosporin. And it was developed, I forget which country it was developed in. It may have been a country in Europe, but he said, I saved the bottle of the first dose of cyclosporin. He reached in his pocket and he pulled it out, and he's like, this was our first dose of cyclosporin from this very bottle right here. And everybody cheered and everything. It was very exciting. But cyclosporin was really developed in 1983, and that changed going from really short-term outcomes to longer-term outcomes, because we had the right sort of immunosuppression treatment for people with transplantation, not just hearts, for every sort of organ transplant. And so in 1990, tacrolimus was approved, also called Prograf or FK506. Most people refer to tacrolimus as Prograf. But that came in 1990. It's almost a decade after cyclosporin. In 1995, mycophenolate came. Everything in transplantation is sort of confusing, because all these drugs have like 3 or 4 different names, and so it's hard. Mycophenolate is called MMF or mycophenolate mofetil, but that came in 1995. Now, everybody remembers, you probably from the nightly news in 2005, the first successful face transplant. Do you remember hearing about this? And so that was in 2005. It seems like just yesterday, but so let's step back here a little bit. So when we talk about heart transplantation, what we're trying to accomplish is taking a recipient who really has a bad heart with a very poor heart failure prognosis, and giving them a possibility at longer life. But we have a limited number of hearts in the United States and in the world, and so there are millions of people with heart disease. And so what we're really looking for a really great heart transplant recipient is somebody who has a poor heart prognosis, but really an absence of a lot of comorbidities, because we want to use those hearts so that people can really have the most benefit and hopefully live a long time. We want that to be successful. And so that's what's involved in doing an evaluation for transplant. So when someone's considered for transplant, they meet with their cardiologist and the transplant team and the surgeons, and they undergo all this testing to get to know their heart, but also get to know their body, their brain, lungs, kidneys, liver, et cetera, to see if there are any comorbidities or problems that would not enable that person to hopefully go a really long time. So this is a section through a heart of a really end-stage heart. We call end-stage heart failure cardiomyopathy, or a disease of the heart. This heart is very dilated. It's gotten very large. The wall is thinned out, and this is the type of heart that would not be working very well, and could be considered that patient could be considered for transplantation. And that's seen here in this cartoon where and someone with heart failure, over time, they go from having a normal sized heart to a more spherical heart that looks more like a balloon, and it becomes larger and larger over time. It works very inefficiently. It's not able to do the job that the person needs to live their lives. And so we say that heart failure is really if you try to define what heart failure is, it's a disease of the heart that causes the person to have decreased longevity, exercise intolerance, so they can't do the things that they want to do, can't go very far, can't walk very far, and the heart has to operate under high filling pressures. And that's what that means is that the heart was working so inefficiently that if you measure the pressures in the heart, that they're all much higher or very abnormal compared to what a normal functioning physiology of the heart would be. So that's a cartoon there. And then so someone goes through the process of having all the testing, goes through the period of listing. We're going to talk about listing, the new listing criteria here in just a minute. But this is what a transplant looks like. So you see the heart in the chest there. The diseased heart is removed, and you can see those little dotted lines on the left there are incisions. So basically the heart is removed at the level of the vessels, the aorta, the red parts in the middle, the inferior vena cava, superior vena cava, the pulmonary artery, and so on. And then, a heart transplant is really not that hard. You just sew in a ring around those areas and take the heart that's been brought to the recipient in a cooler, and I'm going to say another thing about that here in a second, and then warmed up, sewed in, and then the heart is restarted. And if you've ever seen a video of this or a television show about this, it's really amazingly exciting and dramatic to see the heart go from not beating to beating and working again and that sort of thing. Now, I want to take an aside here because one of the new things that we're doing is, and you may hear this on the news, and it's commonly called, like in the media, the heart in a box. And so there is a new technique where it gives us a little bit more time to get a donor heart to a recipient, because the heart for the donor is taken out. The recipient has already been identified. The surgeons go to the donor, they take the heart out, and they basically hook it up to a perfusion device that gives the heart oxygen, and it stays beating in a box. And so if you Google this, you'll see this. You just Google heart in a box. It's also called DCD transplantation. But you basically carry around this box, and the heart is in there beating, and you transport it back to the recipient. And we've had good outcomes with this. We've been doing this for a few years now total in the world. The Europeans started doing this a little bit before us. But because the heart is beating and it's well perfused and gets oxygen, it gives us a little bit more time to do the surgery, and we think the outcomes will be very similar to what we've had in the past. And so that's an exciting thing. I invite you to look at that on the internet or on the news and see. But that gives us a new technology to look at. So heart transplant, as I've tried to say, is a treatment for refractory end-stage heart failure. And also, as I've said, we have millions of people with heart disease, but we really only have in the United States about 2,000 to 3,000 donor hearts per year. It might be that as we do more of these heart in a box procedures, that we're able to acquire more donor hearts and help more people as we go into the future. And so this is where we are now, but we have a vast shortage of donor hearts in the United States compared to the amount of heart disease that we have. So this is another picture of that here. So this is just how the transplant procedure is done. The donor heart or the recipient's heart is removed over on the left. The donor heart comes in and is attached at the level of the superior vena cava, inferior vena cava, aorta, and pulmonary arteries, and so on. and then the heart is warmed up and starts beating, and the whole transplant procedure usually takes 4 to 6 hours on average for the surgery. The patient is then taken to the ICU for post-operative care. Transplant, average stay after transplant in the hospital is about 10 to 14 days. And during that time, the patient gets used to medications and so on. And we'll talk more about post-transplant phase here in a minute. Now, one of the big things that has happened in the last couple of years, as of October of 2018, is that we now have a new heart allocation system in the United States. And that has really changed a lot about how donors are matched with recipients. So I'm going to go over a little bit of that, just so you know, because it's really worth knowing and seeing how we do it. In the past, what we had were 3 urgency statuses, or 3 statuses: 1A, 1B, and 2. 1A would be the most urgent. Those are people who are in the ICU. They're very, very sick, and we say, on average, that 1As were people who might die without a heart within days. Same is true. 1Bs were people who might die from heart disease within weeks. Status 2 are people who were less sick, who are at home. They may be at risk of getting sicker or dying in the next months. And so, as we've always done in transplantation, we try to make sure that donor hearts go to the sickest people. And so that's why we have these statuses. And so 1A is most urgent, 2 is less urgent. And really what we had in the past and now is that hearts are matched by biological parameters. Okay, so primarily blood type and size. Okay, so in other words, you can't take a heart from a 5-foot tall woman and have it work well in a 6'5", 300-pound man. That's not going to work too well. And the flip of that is also true. So we have to really use blood type and size in order to match people up. And also distance is important. So we in the past, especially before we considered the heart in a box concept, we were not able to take donors from California and bring them to Georgia, for instance, because it would take too long. The heart would not be good. The surgery would not be successful. And so people on the list were also stratified by time on the list. So the more time you had on the list, the preference, or not the preference, the people higher on the list would be the people who had the longest time on the list. And so waiting time was a tiebreaker for people. And so what happened with that was that we had a situation where we had growing numbers of people on the list, and we needed to really risk stratify people in different ways in our present era, because we had a lot of people who were getting newer technologies, and we had to work through that as a medical community. For instance, we had a lot more people in the last 10 years getting assist devices, artificial hearts, things like being on ECMO. ECMO is like being on bypass, where you're in the ICU and your blood is going into a machine and pumped back into you in order to keep you alive, sort of like bypass during heart surgery. We also had better understanding of candidate risk, where we needed to have more categories in order to have people risk stratified from the sickest to the least sick in better ways, so that we could get hearts to the sickest people. And the goal of these changes that came about in October of 2018 were to reduce waiting list deaths and to really get the most urgent patients soonest, and to broaden their access to hearts. And so what happened was we went from 3 categories of status to 6, and these involved a lot more specific criteria. And we increased for statuses 1 and 2, which are the new statuses 1 and 2, the very sickest people. The geographic range went up to 500 miles. It used to be a smaller area, so sickest people could pull hearts on the transplant list up to 500 miles away. And that looks like this. So in Atlanta, we could go, locally in Georgia up to 500 miles. Now the East Coast is tough. The East Coast and West Coast this is just a comment on an editorial, but Atlanta lives about 2 to 3 hour flight to 75% of the U.S. population. So there's a lot more competition for heart transplants on the East Coast compared to West Coast. You can imagine how this might affect, these changes might affect a transplant center differently if they're in Colorado, for instance, or Nebraska or something like that. So these changes were met with a lot of debate and so on, but it's what panned out and it's what we have now. What did not change is the urgency status for pediatric candidates, and people are still matched, like I said, according to blood type and size. That just has to be the case because of physiology. The hope was when these changes took place a couple years ago would be that more transplants would happen for the sickest candidates, and then we would see that people would have less time potentially on the list. But the idea was to monitor and improve the system as needed. And so far, the system has, this is a whole other talk by itself, but so far the system has been okay. Each region of the United States has seen different outcomes. So there may be some tweaks of this as we go into the future. I would say, for the most part, what we've seen is that that for 1 year survival for transplant has gone down a little bit, because the reason for that is that we've taken these people who are the sickest of the sick, who are in the ICU, for instance, on ECMO and artificial hearts and high levels of life support, and we're taking more of those people to transplant. And so you can imagine that if you take more people who are sicker and really, really sicker, the chances of having a complication are higher. And that's definitely the case, because we're doing a extraordinary surgery on people, and the sicker you are going in, the sicker you may be on the other side. And so we have to, as a medical community, think about that. And so another way to say this with the new criteria is in this slide here, that if you're on the transplant list, you're more likely to get a transplant if you're on ECMO, or if you're really, really sick and you're in the ICU and you have a complication that has made your situation very complicated. If you're on life support medicines, all the things here on the left side of the screen, you have life-threatening arrhythmias and so on. Or if you need multiple organs, let's say you need a heart lung or a heart kidney or so on. But it's likely lower to get a donor heart in the current system if you don't have those things. If you're more of a stable patient, if you're a VAD patient, an assist device patient, if you're not in the hospital, so those people are more stable. But the medical community would say that, well, if you're stable, you're stable, and really the heart should really go to the people who are the sickest. And so that brings up a lot of kind of philosophical and ethical issues. So here are the current statuses, and I'll just show this real quickly. So this is the current status. Instead of 1A, 1B, and 2, we have 1 through 6. Status 1 are the sickest of the sick. Those are the people who are on ECMO, who are like the bypass patients. Who MCSD is mechanical circulatory support. So who are on temporary LVADs, temporary pumps that are keeping them alive, with things like ventricular arrhythmias and so on. Status 2 patients are people who have complications from an LVAD or balloon pumps or those sorts of things. And you see as we go farther down here, these are status 3 patients are not as sick patients, but they may be on milrinone or be a more stable VAD patient. They're people who have been sort of stabilized on ECMO, or they have an LVAD and they have an infection or these sorts of things. So basically we're going from sicker patients down to less sick patients. And the status 4 patients are patients who are waiting at home, like with an LVAD, or they're on home milrinone, patients not in the hospital. And so I didn't even show the 5 and 6, but it gives you the idea of where we are. Now, in addition to this, there's no way, there are about 1,000 other criteria that go underneath each one of these in order to really risk stratify people. And I don't have time or space to show all those, but there are all these blood pressure and hemodynamic criteria that go into being a status 2, for instance, or a 3, and you have to meet all. And so, in other words, it got really, really strict, especially high up on the list. You had to meet a lot of very, very strict criteria in order to be high on the list. And so now what has also happened in the last 10 years, and I've alluded to this earlier, is that a lot more people are having assist devices placed. So it's harder to get a heart transplant, especially because we have very few donors. But a lot more people, so VAD technology has gotten a lot better, and a lot more people are going for VADs because it works well. LVADs can keep patients alive until they get a transplant, even if it's years. We have many patients in our program who have assist devices for over 10 years now, and they do really, really well. So I should step back and say that LVADs are these pumps on the screen here, and there are a variety of them that are mechanical pumps that are implanted by the surgeon, and they keep people alive until either the end of their life or they get a transplant. And we call that, this is a very important thing, we call patients who are not candidates for a transplant, we call that situation destination therapy. And so that means that the patient, the idea would be that patient has the destination of an LVAD until the end of their life. And hopefully that's a really long time. As you may know, we don't usually transplant a lot of patients more than 70 years old, especially at Emory. So let's say I saw a number of people this week who are in their upper 70s who have worsening heart failure. Those patients would likely not be a candidate anywhere in the US for a transplant, but we could consider them for an LVAD. That would be destination therapy, because we could have them get an LVAD and maybe have them live several more years or many more years and see graduations, weddings, and all the family events that they want to have. Now, these devices are just like transplant, they're also very complicated. With a transplant, there's all the issue of immunosuppression and anti-rejection medications. These devices the care of them revolves around managing the batteries in the computer. And you can see in a couple of these pictures here that there's other equipment that has to run the pump and that sort of thing. But on average, these really work quite well and are really good for patients. So here's a kind of a comparison between LVADs and transplant. So with a transplant, we're replacing the heart. We're taking someone else's heart and using that. It requires ongoing immunosuppression and monitoring and monitoring for rejection with biopsies. And it comes along with its own set of problems, which we'll talk about in a minute. There are psychosocial adjustments and so on with dealing with having gone through a heart transplant. With an LVAD, there's not the immunosuppression, but there's the care of the device. So it's another set of things to manage. And all patients with assist devices have to be on blood thinning agents like Coumadin, because we don't want pumps to clot off or develop a problem with a clot in the pump. And so there are potential side effects on either side or complications of either side, whether it be transplantation or assist devices. But on average, we do pretty well with either one. And it's the job of the transplant and the VAD team and the heart failure team to guide patients and their families and do education about what the what options are available, and so on, and how we choose that with the whole team. And so, all right, so let's talk a few minutes about post-transplant. So let's say somebody goes through all these things we've talked about, and then they have a heart transplant. They are in the hospital for a week or two, and they go home, or we're getting ready to go home. What do we do? We focus on a variety of really important things. First is patient education. So we do a lot of very intense education about the patient's medications. These are primarily the anti-rejection medications. And we also do a lot of education about diet, food safety, heart healthy diet, low cholesterol diet, and so on, because we want that heart to be healthy and safe for a long time. We monitor blood pressure very carefully. A lot of transplant patients have high blood pressure, so we treat that. And that also involves a lot of education and so on. We teach patients, okay, if you have a question, who do you call? Where do you go? What do you look for? What do you do if you have a fever, for instance, or you notice a problem? We make sure that success is teed up in the best way possible. And a lot of patients do undergo either inpatient or outpatient rehab. We send almost all of our patients to outpatient rehab after they go home, so they can build up their exercise tolerance and their exercise capacity as we go into the next many years. I want to take an aside there and say that, you know, across the country, heart transplantation does really a great job. We have a lot of patients in Georgia who are 20 and 30 years out from their transplant. And if you take all the patients in the US and look at the average lifespan for heart transplantation, it's about 13 years. So that's, some people don't do as well as 13 years. Some people do a lot better than 13 years. But if I can say that if people are really good about doing all the things, then on average we can do quite well. At least if we're monitoring for any rejection or other things. There are patients, unfortunately, who do have different types of rejection. I'll mention that here in a minute, and that can be some problems. But on average, heart transplantation does quite well. And so everybody always asks, well, if I have a heart transplant, I would like to say thank you to the donor family. How does that work? A lot of donor families are grieving and the loss of their loved one, and may not be approachable or may not want to have communication with their recipient family or their recipient. Some do, but the mechanism for that is some recipients want to write a letter that goes through UNOS and sort of in an anonymous fashion gets sent from UNOS to the recipient family. And then at that point, the donor family may or may not respond, just depending on their feeling about things. But we have had a number of recipients meet their donor families, and it's often a very wonderful and beautiful thing. We've even had a couple of families, the donor family wanted to hear the heart of their loved one in the recipient. And so we've had both families come in, they get to meet each other, and then the donor family gets to, you know, put their hand or listen to a stethoscope of their loved one, and it's usually very touching and emotional at that time. Back to post-transplant stuff. So after a transplant, there are a number of things that involve surveillance. There are regular office visits. Basically, it happens where there's a lot of upfront, regular, frequent visits, sometimes weekly or biweekly, and over time it gets spaced out. On average, about in the first year, there are 15 to 20 or more biopsies that are done of the heart, to monitor for rejection. There are a lot of ultrasounds, echoes, lab tests, EKGs, and so on. But all of this is to monitor the heart function and to watch for rejection. This is how it takes about 5 to 10 minutes. A catheter is snaked down from the internal jugular vein down to the heart. And you can see on this little slide here, there's a tiny little pair of forceps on the tip of that. And it takes these little pin-sized little pieces out of the inside of the heart, and we look at it under the microscope and watch for rejection or any signs of inflammation in the heart. Now, rejection and treatment of rejection is a whole topic in and of itself, but here are a couple of things about that. Now, there are different types of rejection. The first is what we call cellular rejection or acute cellular rejection. That involves inflammation of the heart, and we see that on a biopsy. And the treatment for that is usually steroids or prednisone. And most of the time that resolves, and we go about our business. And a lot of patients do have that in the first year. I'll show a slide of that in a minute. But it's not uncommon to have some rejection in the first year that's easily treated. There are types of rejection that are more difficult to be treated, but it's a little more rare. There's another form of rejection called what we call chronic rejection or cardiac allograft vasculopathy. That's not cellular rejection, but it basically involves narrowing of the heart arteries over time. And it's related to the body not liking, the recipient's body not liking the donor, and particularly the donor vessels. And so this is kind of a rejection of the vessels. And over time, those arteries can become narrowed. There's also something called antibody-mediated rejection, where antibodies from the recipient start attacking the donor. And there are different things that we look at on the biopsy results to look for that and to watch for that. And it's treated in a totally different way in many cases than just regular, what I would call garden variety cellular rejection, which is not that uncommon. And so really what it comes down to is for a transplant recipient is that taking the immunosuppression really as directed and not really missing any of it and really keeping track of it is very, very important. We can really ensure success or achieve success by doing all the things that we're supposed to do. And I always tell people, keep a list of your medicines, because in the first year, especially, there are a lot of changes in medicine. So if you just look at the bottles and do it's likely that what's written on the bottle is not the most recent. So keep a list, and every visit, if something gets changed, write down those changes on your list. And that way you've got a really up-to-date form of the regimen and how to do the prednisone and the Prograft and so on, so that everybody is up to speed on exactly how to take those medicines, and everything is updated very easily and over time. And so this is what I was saying here a minute ago. So the rejection rate is the highest in the first year or two. So in one study, about 40% of people had no rejection episodes. 40% had one episode, and 23% had more than one episode. So you see that some cellular rejection is not that uncommon in the first year. And so, but the global process is that people with heart transplants are on anti-rejection medicines for the rest of their life in order to try to prevent that rejection. Now, the good thing is that transplant patients are often on the most transplant medication for the first year, and sometimes even for the first 6 months, because usually between 6 months and a year, the prednisone is weaned down to a low level. Sometimes we do need to continue prednisone, but a good portion of patients will be on 3 drugs for the first year, and then sometimes, or a lot of times, only on 2 drugs after that. And so those are the immunosuppression drugs, not including all other drugs, of course. But anti-rejection drugs are very important for the rest of the patient's life, and they're often adjusted by the transplant team. So that patient and their family just really needs to keep up with where you are, what to be taking, because if there's any confusion about that, that can cause some problems. Now, especially in the first year or two, one of the other issues as far as complications goes is infection. We look for rejection, we look for infection. And so we're trying to balance those things because immunosuppression makes people more likely to have infection of some kind. One of the infections that we really look out for is CMV or cytomegalovirus. It goes along with being immunosuppressed. And transplant teams will monitor people for any signs of CMV. We often use prophylactic medication to prevent CMV or other infections. We like people to use masks for the first weeks and months. Now these comments are sort of in the pre-COVID era. I'm going to talk about COVID-19 here in a minute, but you can imagine that we have a lot of different types of transplant patients. We have transplant patients who have their heart transplanted and they're 35 and they got 4 kids who are going to elementary school at home. So their ability to pick up a virus or a cold virus or something is higher than somebody who has less exposure. But we like people to sort of socially distance for the most part in the first few months and do the best they can with hand washing in order to try to not get common infections that are out there in the community, particularly influenza. Okay, so we like everybody to get their flu shots and be very careful about that. I'll say a couple of other minor things about coronavirus here in just a second. Now, long-term post-transplant, the things that we look for or worry about are, because of immunosuppression, we look for things like cancers. And because of the immunosuppression, there is a risk lifelong that is higher than the average population for things like colon cancer, breast cancer, lung cancer, et cetera, et cetera, et cetera. So everybody needs to see their dermatologist and watch for skin cancers, wear sunscreen. Women need to have their mammograms and pap smears and all the usual things that we do. And that's also sort of managed by the transplant team and their primary care team to watch for these sorts of things. Osteoporosis is sometimes present because of the use of steroids. It can weaken the bones. So we do scans of the bones called DEXA scans. We have certain patients who do develop osteoporosis, see the osteoporosis mineral metabolism group to make sure they have the right amount of vitamin D and calcium and so on. Hypertension, I said this earlier, but hypertension is very important. It's very prevalent after heart transplantation. And so is hyperlipidemia. So we watch people's blood pressure and their cholesterol. Everybody gets routine heart caths over time according to a particular schedule to look at those heart arteries and to monitor for rejection and so on. Now, and also diabetes. On the bottom of the screen, you'll see that diabetes is more common in the transplant population. Now, mood and psychological issues are also incredibly important. We know that people who go through the transplant process are at risk of having anxiety and depression. And we like for people to have the right access to counseling or a psychologist or a psychiatrist if at all necessary. We strongly encourage that. It's also why we encourage people to do the things that we're doing here today, meet people and talk about themselves and their story and their process so that we can share amongst ourselves and learn about the things that we need to be doing to care for ourselves. And of course, right now is a difficult time in our country with the pandemic. We're isolated more, and it's more of a difficult time in dealing with stress and anxiety. So it's an important topic for us. So as I've said, the first year is very intense for patients. There's a lot of medications. There's an immunosuppression regimen that's very key. We like for people to get through that time and recover and rehab, and if possible, resume a normal lifestyle, exercise, going back to work, taking care of their family, being active, doing rehab, and all those things. And so, but there's no doubt there are a lot of visits and tests and so on. So if you take, this is the United States data. So if you look at on average, this includes people who are the sickest of the sick who get transplants on down to people who are not so sick. This is everybody put together in one thing, but on average, 1 year survival rates are about 90%, 3 year survival rates are about 75%. And so heart transplantation usually does well for a lot of people, but the issues that do arise are the ones that we've talked about today, and we watch very closely for those things. Okay, so I'm going to say a couple things here about COVID-19. And so there is not a lot of data about heart transplantation in the last few months, but there are some guidelines out there, and every center is very worried about, you know, pre-transplant patients, post-transplant patients, and how we manage the issues of coronavirus. What I want to say is that this is anecdotal data, but you know, from what I have seen and what our team has seen in the last several months is that we've had a number of transplant patients have coronavirus in our system, and most have done really well. I've got 2 or 3 in the last week, and we've done really well with that. But there's a lot of worry about the transplant patient in general because of the immunosuppression, and the risk is high. But so far, I personally have not seen that borne out with a lot of bad problems, at least in the transplant population. And so we have to watch that carefully. But most importantly, our transplant patients, we remind them all the time to be very safe. Testing is key. So if someone with a transplant who's post-transplant starts having symptoms of coronavirus, COVID-19, we are looking for shortness of breath, fevers, chills, all the things that you've seen on the news. We immediately do a test. So as far as the actual transplant process, you know, before, if someone is waiting for a heart, there's a lot of testing that goes on if a donor is identified. The donor is tested, the recipient's tested very frequently, but we're not actively doing transplants on people who have coronavirus, and for obvious reasons, because of the risk of that and the immunosuppression and so on. One very important key, and this just came out, the transplant guidelines were just sort of updated about coronavirus just recently, and we haven't really seen a lot of donor to recipient transmission, especially in the heart population. It's probably been seen somewhere in the world. I don't know of that for any other organ systems, you know, like for kidney or so on. But I think that we have not really seen donor to recipient transmission, at least at any important level. But maybe we'll see something on the news or some other guidelines about that if it happens. Obviously, that would be a very worrisome situation. So it is a new world, and so the coronavirus not only affects all of us in what we're doing or not doing in our lives, but also affects this area of heart transplantation, and we have to be very careful. So please distance, wash your hands, wear your masks, protect each other, and especially at this time where things are really increasing for us with regard to the prevalence of the virus. And so what I've tried to do is going to give a scheme of a lot of different issues about heart transplantation in our current time. And I don't want to go on a much longer, but I want to see if anybody has any questions for me before we go out into the afternoon. I hope you've had some helpful information here.
Denise asked if most heart recipients are CHD patients or acquired heart disease patients.
So we have for our heart transplant patients are really a combination of all things. So I guess the best way I can describe that is that by saying that about 50% of end-stage heart failure patients have coronary artery disease. Okay, and about the other 50% have all the other things. That can be congenital heart disease, what we call non-ischemic. Non-ischemic means you don't have coronary disease. That's where the heart failure is due to hypertension or other factors, genetic factors, and so on and so on and so on. There are hundreds of different causes, but as far as coronary artery disease, it's about 50% of the patients that we see who develop end-stage cardiomyopathy. I want to say one other thing about that. There are a few things that are sort of up and coming in this area that are very important. Just in case you hear it on the news or read a newspaper article, we've known about this very complicated disease for a long time called amyloidosis. And this is a disease that affects the heart. There are many kinds of this disease, but we now have some new treatments for amyloidosis. This is a topic in and of itself, but really in the last 2 years, we've had treatments, and that's led to a lot of testing for this problem. And we're now hoping that these new treatments may lead to better care of patients with this inherited form of amyloidosis. So if you ever hear that terminology on the news, you'll have heard it at the Georgia Atlanta TNT, and you'll know a little bit about it. You may see ads for this. You may see ads for these new drugs for people with amyloidosis.
Can you have an LVAD after you've already had a heart, if the heart has failed?
You mean a heart transplant and then get an LVAD? That would be extremely rare. It has been done. I've seen that maybe once or twice, but that would be an extremely unusual situation, because you have somebody with a heart transplant who requires immunosuppression, who also has the right characteristics where they might benefit from an LVAD, and they're able to care for an LVAD and be functional in a variety of different ways that are important for the management of that. So the answer is yes, but it's extremely, extremely rare. If somebody has a heart transplant that doesn't do well, some patients, it's also quite rare, but some patients could be considered for a second heart transplant. Like I said, it's very rare, but then it involves going through the heart transplant process again, and still being, still kind of passing all the tests and doing all those things. And so I've seen some patients get second or even third heart transplants before, but that's a complicated thing, and that's something that comes up for an individual. You won't see a lot of data about that. You'll read newspaper articles and stuff, but I've had a few patients go through that process on either side, either a re-heart transplant or other types of mechanical support.
Yes, we have one with us today that's gotten two.
I see you there. I see you. I see you. Yeah.
In the new criteria for potentially being listed for a heart transplant, where does the age of the patient come in?
So age is center dependent. There's not a U.S. national guideline for that. But for most centers in the U.S., it's about 70. Okay. Actually, it's increased a little bit in the last 5 or 10 years. So I would say that most centers several years ago at least had it around 65, and so. But I think that most centers have it around 70. I've had a couple of patients, or I've known of a couple of patients who have had a heart transplant at age 71 or 72. We don't particularly do that at Emory, but it's really based on the transplant committee, the center, and the patient and their families, but not a national guideline according to those criteria that I gave you a little while ago.
Okay. How important is genetic testing in heart disease, like DCM or HCM?
We should probably talk about that sometime. It's very difficult to answer that question in a short fashion. But genetic testing has been important for a long time, and it's increasingly important in the last few years, just because we have the tools for doing genetic testing have improved, and we can now very quickly screen for hundreds of or thousands of mutations in cardiac proteins in a quick fashion. And so I guess what I would say in brief fashion about that is when we see a patient who seems to has to be a family history, you know, multiple members of their family who have had heart failure or cardiomyopathy, those are the patients that really that we really immediately think, oh, let's do some genetic testing and see if we can find some information that may be helpful. The reason that may be helpful is there are different types of genetic mutations that may make people more likely to progress with their disease or have arrhythmias or so on and so on. So we like that information. It also gives us the opportunity to screen other family members and think about the family as a whole. So it's increasingly important, and it also relates to amyloidosis. We do a lot of genetic screening for amyloidosis. So it's something that for people who have a family, multiple members in their family who particularly have had heart failure, cardiomyopathy, that should be inquired about by the patient and their family to do the genetic testing.
Okay. And any other questions, anyone? I think we're small enough you can just unmute and speak up if you have anything. Well, if there's no other questions, we want to thank Dr. Markham. He was on call this morning, so he had to spread his time out so that he had time to share with us, and we appreciate him. And I appreciate seeing all of you and hope we get to see each other in person really soon. We've had enough of this.
I appreciate all of you too. I hope you have a quiet and peaceful weekend, and we'll see you at some future GTF events. So have a good afternoon.
Thank you.
Thank you, everyone.
Is that it, Pat? Are we done? Oh,
That's it. You're done.
Okay. Thank you all.
Thank you so much for being with us.
Greetings from Florida.
Ah, I'm jealous. We want to be there too.
It's not a nice day today, but that's okay. So, y'all take care. It was good to see everyone. Thank you.
It was good to see you. Bye-bye.
Bye-bye. That's it.